Bismillah ar-Rahman ar-Rahim. In the name of God, most gracious, most merciful. I would like to welcome all the students who thankfully joined this lecture. And for optimum use of time, I kindly request you to keep your comments and questions after the presentation. If you have urgent comment, please raise hands. You can find this lecture and other lectures on my YouTube channel named Professor Abdussalam Yasin Taha, and this is the link of this channel. How to perform pulmonary lobectomy and pneumonectomy step by step. This is the topic of our lecture of today. In this lecture, we will display the procedures of right-sided and left-sided lung resections step by step. And this lecture actually is part 2 of the subject, as the first part was principles of pulmonary resection. And I would like to remind you that for almost any lung resection, dissection is done in the lung hilum and or the interlobar fissure. Therefore, it is very crucial for the surgeon to know the anatomy of the lung hilum and the interlobar fissure in a very good way, so that dissection is done safely to perform different types of lung resection. In this slide, we can see the right interlobar fissure. The fissure has been completed and the segmental arteries to the upper, middle, and lower lobes have been identified. The first step in doing lung resection is to enter the thoracic cavity, and any adhesions between the lung and the chest wall, diaphragm, the pericardium should be divided by blunt and sharp dissection. And then, if the case is a case of tumor, we have to palpate the tumor mass to determine whether the tumor is resectable or not before proceeding to the other steps. And the role of the assistant in pulmonary resection is very important. The assistant will apply traction on both lobes while the surgeon performs the dissection in the interlobar fissure. And when the dissection is completed, we should be able to identify the different segmental arteries to the different lobes of the lung. So this is the middle lobe, this is the right lower lobe, and this is the left lower lobe. This is the interlobar pulmonary artery, giving rise to the middle lobe artery anteriorly, and opposite to it is the superior segmental branch to the lower lobe, and the basilar segmental arteries to the right lower lobe. And this is the posterior ascending branch to the right upper lobe, accompanied by the posterior segmental branch of the right superior pulmonary vein. And during the interlobar dissection, we may face lymph nodes which are adherent and may obscure the arterial branches, especially when we have an inflammatory process, chronic inflammatory process like tuberculosis, bronchitis, etc. The lymph nodes may have the appearance of a blood vessel. Therefore, they should be dissected carefully until the underlying arterial branches are found. In this view, we can see the anterior aspect of the right hilum. The mediastinal pleura has been opened. The right lung is retracted posteriorly, and this is the arch of the azygous vein joining the superior vena cava. The phrenic nerve runs on the lateral aspect of the pericardium, and the vagus nerve in between the trachea and the esophagus. When the mediastinal pleura on the anterior surface of the pleura is opened, we can see the pulmonary vessels, the right superior pulmonary vein, which drains the right upper lobe and the right middle lobe. The middle lobe vein is the most inferior branch or tributary of the right superior pulmonary vein. The right superior pulmonary vein is located anterior to the pulmonary artery. The right pulmonary artery on the right side gives, first of all, the truncus anterior branch, which gives segmental arteries to the anterior segment and the apical segment, and then goes and descends in the interlobar fissure to give the remaining segmental arteries to the middle lobe and the lower lobe. We have to take care of possible anatomical variations of the pulmonary vasculature. Sometimes the middle lobe vein drains or arises from the intracardiac portion of the superior pulmonary vein, and other variations may be present. We have to be careful about that. This is another view of the right interlobar fissure, and in this view, the right middle lobe artery has been ligated and divided during the procedure of right middle lobectomy. What remains is the middle lobe bronchus, which should be also divided and closed in order to do middle lobectomy. So as we said, the assistant has a vital role by applying traction during interlobar fissure dissection. A right angle clamp, such as O'Shaughnessy forceps and good dissecting scissors, are vital instruments for the dissection and isolation of the pulmonary vessels. And we have to carefully dissect the pulmonary vessels using peanut dissector and sharp scissors. In this view, we can see the posterior aspect of the right hilum. The lung is retracted anteriorly, and this is the right inferior pulmonary vein, which is located at the base of the pulmonary ligament. And this vessel actually is a short and broad vessel. For its full isolation, we need to do dissection at both anterior and posterior aspect of the hilum. Any loose areolar tissue around the vein should be removed, as well as a lymph node called sentinel lymph node should be also removed. This is the right brainstem bronchus, which gives rise to the right upper lobe and the bronchus intermedius. Well, this is the surgeon's view of the right interlobar fissure after division of the lower lobe vessels. During right lower lobectomy, the fissure dissection is completed. Now here we have the segmental arterial branches to the right lower lobe, the superior segmental artery and the basal segmental arteries have been ligated and divided. And this is the right lower lobe bronchus have been divided after applying a stapler. And this is the inferior pulmonary vein, the inferior pulmonary vein on the right side, has also been divided after applying a stapler. And the right lower lobe has been removed. So this is the final appearance after doing right lower lobectomy. Now on the left side, the anatomy is a bit different from the right side. If we look here, we can see the left upper lobe retracted anteriorly, while the left lower lobe is retracted posteriorly. And this is the arch of the aorta and the descending aorta. The left vagus nerve giving rise to the left recurrent laryngeal nerve around the ligamentum arteriosum. And this is the left pulmonary artery, which descends in the interlobar fissure, giving rise to different segmental arteries. So this is the anterior segmental artery, and this is the apico-posterior segmental artery. And then we have the lingular segmental artery, or artery sometimes. This is the superior segmental artery to the lower lobe, and these are the basilar segmental arteries of the left lower lobe. In this view, we can see the anterior aspect of the left hilum. Now the lung is retracted posteriorly, and this is the left pulmonary artery located at the superior aspect of the left hilum, and anterior to it is the superior pulmonary vein, which drains the left upper lobe, and the most inferior branch is the lingular segmental vein. And we have to mention an important point. Whenever interlobar vascular dissection is risky, we have to perform a proximal control of the pulmonary artery. So if we go back to this slide, for example, if we find that the interlobar dissection is risky because of adhesions, scarring, the presence of adherent lymph nodes, etc., and we think or we are afraid from the possible injury of the pulmonary artery in this region, we have to go and do a vascular control of the pulmonary artery in the region of the hilum, so that whenever we have an injury to the pulmonary vessel, we can simply apply a vascular clamp here until we control the bleeding. Now this is the appearance of the left interlobar fissure after ligation and division of the segmental arteries of the left upper lobe during the procedure of left upper lobectomy. So this is the anterior segmental artery, this is the apico-posterior segmental artery, and this is the lingular segmental artery, and this is the left upper lobe bronchus, which should be divided and sutured or stapled in order to complete the steps of the left upper lobectomy. So be careful in case of chronic inflammatory conditions in which a perivascular plane is difficult to be sought. Now this is the posterior aspect of the left hilum. The left lung is retracted anteriorly, and this is the left pulmonary artery. This is the left mediastinum bronchus, dividing into the left upper lobe and left lower lobe bronchi, and this is the left inferior pulmonary vein. For controlling the pulmonary veins, there are different techniques. One may use a stapler, which is very quick and easy method. If we don't have a stapler, we can use ligatures. We can apply ligatures or suture ligatures, and we divide the vessel in between the ligatures. The problem with the inferior pulmonary veins, these veins are usually broad and short, especially on the right side. The left side is a bit longer. Therefore, if we use ligature as a method of controlling the pulmonary veins, there is a possibility of slippage of the ligature. Therefore, what I used to do myself, I used to apply a vascular clamp on the proximal side and ligatures on the lung side. Then I divide the vein in between, and I suture the proximal stump with 4O polypropylene suture in 2 layers. First layer is the continuous mattress layer, and the second layer is a continuous over and over layer, so that we are definitely sure of a good control of the pulmonary vein without a possibility of bleeding. Now, this is the appearance of the left interlobar fissure during the procedure of left lower lobectomy. The left upper lobe is retracted anteriorly. The left lower lobe is retracted posteriorly. The segmental arteries to the left lower lobe have been ligated and divided, including the superior segmental branch and the basilar segmental branch. What remains is the superior segmental bronchus and the basilar segmental bronchus of the lower lobe. Well, there are 2 methods of dividing the bronchi of the left lower lobe. One method is to divide the bronchus in one session, like that oblique line of bronchial division. And the second method is to divide the superior segmental bronchus and the basilar segmental bronchi in a separate way. Okay, on the right side, because of the proximity of the middle lobe bronchus, we have to be sure that the site of bronchial division is not very close to the middle lobe bronchus. But on the left side, we don't have this problem of the middle lobe bronchus. Therefore, we can apply an oblique line of division, a single line of division of the bronchus, like what you can see here in this slide. Now, in this slide, we can see the posterior aspect of the left hilum. The left lung is retracted anteriorly, and here we can see that the left mediastinal bronchus has been divided after applying a stapler, and the left pulmonary artery is also divided after applying a stapler. And this is the distal stump of the left mediastinal bronchus. What remains is the left superior and left inferior pulmonary veins. Well, what to do if an inadvertent injury of pulmonary vessels happens? This is a rare but possible complication that happens during pulmonary resection. Inadvertent injury of pulmonary vessels is a mishap which requires a good plan of action to save the patient's life. So the advice is to be quiet, try to get a proximal control of the pulmonary artery if you haven't already done that. Use suction and finger pressure on site of the bleeding while you continue dissection. Make use of autotransfusion if available. Let your anesthesiologist and your team know what is going on. Infuse fluid and transfuse blood, and so on. So this is one of the serious complications that you have to deal with it carefully. Otherwise, you may end with a disaster. You may lose your patient. Now, in the coming slides, I'm going to show or to demonstrate some procedures of lung resections and pictures. What we can see here is the anterior aspect of the right hilum. This is the inferior and the superior pulmonary vein, and that is the right pulmonary artery, and behind it is the main stem bronchus. Now, in order to do right pneumonectomy, we have to deal with all the bronchovascular structures in the lung hilum. So what you can see here is the ligated and divided inferior and superior pulmonary veins, and the stippled and divided right pulmonary artery. And now the right main stem bronchus is being stippled and to be divided. And this is the final appearance of the lung hilum after completion of right pneumonectomy. The inferior and superior pulmonary veins, the right pulmonary artery, and the stump of the right main bronchus. Here we can see the procedure of left pneumonectomy in pictures. This is the position of the patient and the left posterolateral thoracotomy incision. And this is the intrathoracic appearance of the left lung. This is the anterior aspect of the left hilum, the left pulmonary artery at the top, and in front of it is the superior pulmonary vein, and at the inferior aspect of the lung hilum is the inferior pulmonary vein, and behind them is the left main stem bronchus. Here, the superior and inferior pulmonary veins have been ligated and divided, and the right pulmonary artery has been stippled and divided, and the last structure is the left main stem bronchus to be stippled and divided. Now, this is a demonstration of the procedure of segmentectomy. As we said, the bronchopulmonary segment actually is the structural unit of the lung, and it is a surgical entity. It has its own segmental bronchus and arteries. So here, the segmental bronchus has been clamped and divided. The segmental arteries have been ligated and divided, and now the surgeon is separating the diseased segment from the healthy segment by going through the intersegmental plane of cleavage. Well, sometimes we may have a tumor protruding into the main stem bronchus, like here, a tumor of the right upper lobe protruding into the right main stem bronchus. So here, right upper lobectomy cannot be performed in the standard way. What we have to do what you call right upper lobe sleeve resection. So here, a sleeve of the right main stem bronchus has been removed, and the remaining right main stem bronchus is anastomosed to the bronchus intermedius. Okay, and in this way, we are going to avoid doing pneumonectomy. Here, what we have is a tumor of the left upper lobe, very close to the main stem bronchus, and cannot be dealt with by a standard left upper lobectomy because of the proximity of the tumor. Therefore, a wedge of the left mediastinum bronchus has been removed, and the remaining left mediastinum bronchus was re-anastomosed with the left lower lobe bronchus, and that's called left upper lobe bronchoplasty. Here we have a tumor of the left lower lobe, very close to the, or protruding into the mediastinum bronchus, and therefore left lower lobe standard lobectomy is not feasible. The solution is to remove a sleeve of the left mediastinum bronchus and doing a sleeve lobectomy, and then re-anastomose the remaining left mediastinum bronchus to the left upper lobe bronchus. Well, here we have a tumor of the left upper lobe bronchus involving the pulmonary artery as well. Therefore, the patient needs a procedure called bronchovascular or double sleeve lobectomy. So we have to remove a segment of a sleeve of the mediastinum bronchus, as we mentioned that before, and we have also to remove a segment of the involved pulmonary artery and do re-anastomosis, and that's why it's called double sleeve lobectomy. Sometimes we have a tumor of the left mediastinum bronchus, and it can be dealt with by also a sleeve lobectomy. Here we have a sleeve of the left mediastinum bronchus has been removed along with the tumor, and the remaining, or the two ends of the mediastinum bronchus are re-anastomosed, okay? And in this way, we avoid doing left pneumonectomy. In this picture, we can see the procedure of division of the pulmonary vessels. As we said before, the pulmonary vessels can be dealt with in different ways. One of the standard ways is to apply ligatures. At least we apply 2 proximal ligatures and 1 distal ligature, or 1 proximal ligature and another suture ligature, and then the vessel is divided next to the proximal 2 ligatures. Okay. Division and suture closure of the bronchus. In this slide, we can see the distal bronchus has been clamped by a special clamp, and no clamp is applied to the proximal bronchial stem to avoid trauma. The bronchus is divided by a knife, and interrupted sutures are applied to the proximal stem until it is sutured completely. So the proximal stem is closed by interrupted sutures without applying a clamp. And after that, of course, we have to ensure that there is an airtight closure of the bronchus by irrigating the stem with normal saline and asking the anesthesiologist to inflate the bronchial and be sure that no bubbles of air escape from the bronchial suture line. And this is the technique of separate lower lobe bronchi division. As we said, the lower lobe has superior segmental bronchus and a basal segmental bronchi. We can divide them separately and or in one session. One of the problems that occur after lung resection is bronchopleural fistula due to the dehiscence of the bronchial stem. So when we have a chemotherapy, radiotherapy, a tumor in the nearby bronchus, and we are afraid from the possibility of bronchopleural fistula, we can do bronchial closure reinforcement by a pedicled flap. So here, a flap of the pleura, sometimes a flap of intercostal muscles or the pericardial fat is used to cover the bronchial stump, okay, in order to minimize the chance of bronchopleural fistula. Now, in the next 4 slides, I'm going to demonstrate actual cases of lung resection in our unit. The first case is a right upper lobectomy for huge pulmonary hiatus cyst destroying the right upper lobe in a boy of 7 years. The patient actually had a bilateral pulmonary hiatus cyst and liver hiatus cyst. So that boy complained of cough and shortness of breath and wheezy chest. His plain chest X-ray revealed a huge homogeneous ovoid opacity in the right upper zone with a shift of the trachea to the opposite side. The CT scan showed a huge cyst in the right lung and another cyst also in the left lung, beside a small cyst in the liver. The patient was operated upon via right thoracotomy, and the right upper lobe was destroyed. Therefore, a decision was done or was made to perform a standard right upper lobectomy, and that's the cavity of the cyst, and that was the laminated membrane of the cyst. And the patient did very well post-operatively. That was the post-operative chest X-ray showing fully expanded right lung, and that was the post-operative CT scan showing a residual small cyst in the left lung, which was scheduled for a subsequent thoracotomy. The second case was a bilobectomy, right middle and right lower lobectomies for chronic bronchiectasis in a boy of 12. So the patient was a teenager complaining of chronic cough and expectoration. The plain X-ray showed an opacity in the right lower zone, and the CT scan showed evidence of bronchiectasis bilaterally, mainly in the basal segments of the right lower lobe. The patient was managed initially conservatively. Rigid bronchoscopy was performed twice, and as you can see, thick offensive pus was drained via the bronchoscope. A culture was obtained, and the patient was prescribed antibiotics accordingly. The patient at operation was found to have that the right middle lobe and the right lower lobe were shrunken and consolidated. Therefore, a decision was made to perform a bilobectomy of the right middle and the right lower lobes, and the patient had a good recovery, and that was the early post-operative chest fill. The third case was right lower lobectomy for solitary metastasis from colonic cancer in a man of 35. So that was a 35 years old man, a known case of carcinoma of the colon managed by right hemicolectomy, presented with an opacity in the right lower zone, and at a previous X-ray performed 6 months earlier was normal. CT scan of the chest of the abdomen revealed no metastasis. Therefore, the decision was taken to perform right thoracotomy and right lower lobectomy for this mass. That was the specimen of the right lower lobe, and the tumor mass is visible here. And the patient did well post-operatively. That was a post-operative chest X-ray with fully expanded right lung. The fourth case was a left pneumonectomy for non-small cell lung cancer in a man of 80. So that was an 80 years old man, a chronic and heavy smoker, with an opacity in the left lower lobe. As you can see, it is evident also on the CT scan. Bronchoscopy revealed a total occlusion of the basal segmental bronchi of the left lower lobe by tumor. The patient was scheduled for left lower lobectomy. Pulmonary function tests were normal or adequate. At the time of the operation, the tumor was more extensive. Therefore, left pneumonectomy was performed, and you can see the tumor mass here. And the diagnosis was a squamous cell carcinoma, and that was the post-operative axis of the chest immediately after left pneumonectomy. So the take-home messages from our lecture: safe pulmonary resection is a technique of anatomical resection through individual hilar dissection and ligation. Mastery of pulmonary resection is indispensable for every thoracic surgeon due to its wide range of indications. Inadvertent pulmonary vessel injury during any pulmonary operation may necessitate pulmonary resection. And besides thoracotomy, standard and uniport VATS are alternative approaches for pulmonary resection, increasingly employed worldwide. However, they are beyond the scope of this lecture. And our next lecture, inshallah, coming soon, is sacrifice little but keep the most. Pulmonary segmentectomy, the art of when and how. And we'll leave you for 2 minutes with the beautiful and amazing nature of Kurdistan. الحمد لله الذي هدانا لهذا